Good morning. It's a pleasure to be able to present here to the advisory committee, and it's always nice to see so many friends and colleagues here in Atlanta. So I'm going to be talking a little bit about trivalent live-attenuated flu vaccine and inactivated influenza vaccine and looking at the comparative safety studies in children. We were really charged with trying to assist the grade process and doing an evidence review for flu vaccine safety in children 2 through 8 years of age. This work was done by a collaborative group called the Pediatric Flu Vaccines Safety Evidence Review Group. It consists of folks from the CDC and folks from the Clinical Immunization Safety Assessment Project, or CISA. I don't know how many of you are familiar with CISA. CISA is a network of folks from the Immunization Safety Office and 7 Research Center. And we're really charged with doing a vaccine safety public health service. We do investigations, research studies related to vaccine safety, review adverse events following immunization, and also look at safety issues regarding immunizations, and so this falls under that rubric. Just to look at potential disclosures for conflict of interest, I must be much more conflicted than my colleagues at Vanderbilt. So our objectives were to evaluate the evidence for the safety of trivalent live-attenuated flu vaccine compared with trivalent inactivated flu vaccine in children aged 2 through 8 years of age using the ACIP grading recommendations or the grade process. And I think Lisa is this is kind of a segue to Lisa's talk. So the ACIP flu working group came up with an assessment, much as Lisa showed, for outcomes for efficacy. They set some guidelines for, or chose outcomes for safety analysis. Among these were immediate hypersensitivity and anaphylaxis, febrile seizure, medically attended wheezing, Guillain-Barré syndrome, other neurologic outcomes, and respiratory symptoms. They graded 4 of these as having critical importance and 2 as being important. Now, we took all these safety outcomes and discussed them intensively in our smaller working group and also in the larger CISA working group. And some of these outcomes, the last 2 being other neurologic outcomes and respiratory symptoms, which were graded as important, were really fairly nonspecific. So we actually did not keep them for our final safety analysis. We did look at several outcomes, anaphylaxis and immediate hypersensitivity and febrile seizures. We did not select them as our final safety outcomes for this review, and for several reasons. Mostly because these events are fairly rare or uncommon, and there's really, if you're looking at the comparative studies, looking at LAIV versus IIV, there really is limited information for review. We decided to keep medically attended wheezing as an outcome for review because this is common and clinically important. Again, Guillain-Barré syndrome, we didn't select. This is a very rare outcome for young children. There's really limited information or none for review in the studies comparing LAIV and IIV. Fever was added as an outcome for these studies because it's common, it's medically important, it's somewhat comparable across the studies, and it's a potential proxy for a febrile seizure risk. So we added that as an outcome. And then we also added serious adverse events as an outcome. We considered it important. It's been used in other safety reviews and includes some of these rare and less common events when you're looking at the studies for LAIV versus IIV. So the methods that we used for our evidence review, there were 8 publications that directly compared LAIV to IIV3 that were selected for review. These manuscripts were reviewed by members of the working group using grading sheets. We looked at outcome definitions, study design, the season in which the studies were conducted, ages of the study population, and sample size. We also then looked at limitations or potentials for biases in the randomized trials. We looked at allocation concealment, blinding, loss to follow-up, failure to adhere to an intention to treat analysis, stopping early for benefit, or failure to report an outcome. For the observational studies, we looked to see if the studies failed to apply or develop appropriate eligibility criteria, if there were flawed measures for exposures or outcomes, or failures to control for confounding. We also graded or looked at each study for indirectness in terms of the population, the intervention, or to see whether the outcome or intervention differed from that of interest, or to see if the vaccines were compared with each other or with placebo but not one another. These assessments were reviewed within the Pediatric Flu Safety Evidence Review Group. They were reviewed by the CISA investigators, and also they have been reviewed with the ACIP Flu Working Group. So amongst the trials, there were 3 that were initially chosen, but then were excluded for various reasons from the safety assessment. There was the CLOVER study, which was conducted in years 86, 87, a population of children 3 to 19 years of age. It was a double-blind placebo-controlled study of around 200 children comparing IIV and nasal saline placebo to saline placebo and bivalent LAIV. However, there were no safety outcomes described in that study, so we eliminated it from our safety assessment. Kathy Newsel's study, as previously mentioned, was conducted over a 5-year period. It was initially conducted in persons between 1 and 65 years of age. Her report reported on subjects under 16 years of age. It was a randomized controlled trial. However, if you're looking at the outcomes of interest in the manuscript, only fever was described as one of the outcomes. And the study was a little problematic in doing comparisons in that the group 2 who received the LAIV only containing 2 flu A strains also received an inactivated monovalent B strain, so you really couldn't do a head-to-head comparison. So we omitted it from our analysis as well. The last study, Holleran, was an open-labeled, non-randomized, community-based intervention done over several years in children 5 to 18 years of age, a fairly large number of subjects, but our safety outcomes, again, were not described in this study, so we eliminated it from our assessment. So that left 5 evaluations for our safety assessment. Some of these you've already heard mentioned today. The Ashkenazi study and the Fleming study are really fairly comparable studies done in the same year or same season. The Ashkenazi study was done in younger children who had recurrent respiratory tract infections, whereas the Fleming study was done in children 6 to 17 years of age with asthma. They were both open-label randomized studies, about the same number of subjects, about 2,000 in each study, and children and adolescents were randomized to get either IIV3 or LAIV. The Belshi article or paper described a study done in the years 2004 and 2005. It was conducted in children 6 to 59 months of age. And this study did include some children with wheezing or a history of asthma. It didn't exclude those children. It was a double-blind, placebo-controlled study where children received either IIV and LAIV placebo or received IIV3 placebo and LAIV. And around 8,000 or more children were enrolled in that study. The last 2 studies were more observational studies conducted over slightly different time periods. The Toback study was a observational study in younger children, 24 to 59 months of age, whereas the Baxter study included children in a slightly older age range. Again, these were observational studies done mostly through the Kaiser system and included fairly large study populations. If you look at our outcomes of interest, fever, medically attended wheezing, and serious adverse events, the first 3 studies describe those as outcomes. The last 2 studies can be used to look at medically attended wheezing and serious adverse events. So we set out to do this and thought, well, we'll start tackling this by looking at fever, thinking that that would be a fairly simple outcome to look at. Well, it's much like the Duke-Syracuse basketball game. It kind of is a little up to interpretation. Was it a block or a charge? I happen to think it was a charge. But anyway, moving on. Fever was described somewhat differently in each study. So if you look, each of these articles did describe fever. The measurements were different from study to study. It was axillary or rectal, oral, or axillary oral or rectal, depending upon the study. The measurement intervals differed from study to study, 10 days up to 15 days. And in the methods, what they described as how they measured fever was a little bit different than how they described fever in the results. So from paper to paper, they were quite different descriptions of fever, making it a little bit more challenging. However, if you look at the outcomes, you can directly compare in each of the studies children who received LAIV to children who received TIV. So for the first paper, the Ashkenazi paper, this study measured temperature during an 11-day period. If you looked at temperature elevations over 37.5 and 38.6, you can see after doses 1 and doses 2, there were no significant differences between the LAIV groups and the TIV groups. In the Fleming paper, looked at fever over a 15-day period. They reported 4 different levels of fever. Remember, these were older children. They only received a single dose of vaccine. And looking at the comparisons, again, there were no observed differences between children who received LAIV and children who received, at that point, TIV or IIV. The last paper did observe some differences in fever rates, the Belshi article. And here is only reported in the paper is day 2 fever. If you look at the BLA application, actually it is broken out over several days, a several-day period. But here in the paper is only reported day 2 of fever after the first dose. And you can see that low-grade fever, or fever over 37.8, there was a significant difference in the rate of fever, being 5.4% in the children who got LAIV versus 2% in children who got TIV. For higher fevers over 38.9, there was no difference reported. So in grading the evidence, we looked at the 4 papers. The Ashkenazi paper, the population differed a little bit from that of interest. It was, some of the children were younger, and these were children who had recurrent respiratory tract infections. For the Fleming paper, it was downgraded somewhat because some of these children were older. They also included asthmatics. In the Belshi paper, some of the children were younger, and none of the children were in the oldest 6 to 96 months age range in the population of interest, which is 2 to 8 years of age. In terms of grading the evidence for limitations and potential for biases for a randomized trial, for Ashkenazi and Fleming, we downgrade a little bit because these were not blinded studies. And all 3 of these studies, there was some loss to follow-up for which to downgrade the evidence a little bit. Moving on to our second outcome of interest, medically attended wheezing. These definitions are a little bit different from study to study as well, making it a little bit difficult to compare between the studies. The Ashkenazi paper defined wheezing episodes observed by a medical practitioner. Fleming, incidence of asthma exacerbation, acute wheezing, illness associated with hospitalization, any unscheduled clinic visit or new prescription, including rescue medication. And Belshi described medically attended wheezing as presence of wheezing on physical exam conducted by a healthcare provider with a prescription for bronchodilator, respiratory distress, or hypoxemia. And Tobeck and Baxter also, these papers defined it similarly, asthma and wheezing being asthma, reactive airway disease, encompassing individuals with a diagnosis of asthma, cough variant asthma, exercise-induced asthma, the term wheezing or shortness of breath, including the diagnosis of wheezing and dyspnea and shortness of breath. The time intervals for study for each of these events for medically attended wheezing did differ a little bit from paper to paper. Ashkenazi admitted the first 10 days after the dosing in their observation period, which one might consider an important time interval to look for medically attended wheezing after dosing. Fleming looked at the 42 days after each dose, as did Belshi and Toback and Baxter. Now, the results reported for each of these studies are reported a little bit differently. This was a little bit confusing to try and tease through, but if you look for the Ashkenazi and Fleming papers, they looked at the percent difference in wheezing between the LAIV groups and the TIV groups, and basically they did not observe any difference in wheezing episodes between either of their groups for these papers after the first dose, and for the Ashkenazi paper after the second dose. Belshi reported adjusted rate differences in wheezing between the LAIV group or difference between the LAIV group and the TIV group. And you can see here that there was some difference in the overall group, but when you age stratify, most of that difference is really in those children, as we all know, under 24 months of age, with the difference being 1.18%. This held true for those who were previously unvaccinated, not in those who had been previously vaccinated and not after a second dose. Now, here's where it becomes a little bit more problematic looking at the observational studies. They looked at hazard ratios comparing rates of wheezing or medically attended wheezing in children after receiving LAIV or IIV. And you can see here when you're comparing in the hazard ratios, you're getting hazard ratios of 0.38 comparing LAIV to IIV, meaning a lower rate in the LAIV group to the IIV group. And this was true for both the Baxter and Toback comparisons. Well, why is that? This really has to do mostly with the current recommendations for how we give LAIV and TIV, meaning that LAIV is not recommended for children who have underlying medical conditions such as asthma, whereas IIV is recommended. So naturally, you would expect wheezing episodes to occur at a higher rate in the IIV group. So these data are confounded. So grading the evidence, again, these are pretty similar to what we looked at before. Population differs from that of interest. Yes, for Ashkenazi, Fleming, and Belshi, adding the Toback and Baxter papers. Toback, the population differed a little bit in that there were none of the children were between 6 and 96 months of age. In the Baxter paper, none of the children were between 24 and 59 months of age. And then if we downgrade the evidence a little bit for the Ashkenazi paper, as I mentioned, because medically attended wheezing wasn't reported in the first 10 days after receipt of the vaccine dose. If you look at other limitations for the randomized trials, again, this looks familiar to the last slide. Ashkenazi and Fleming were not blinded. There was loss to follow-up in the 3 studies. And then if you're looking at for the observational studies, as I already mentioned, Toback and Baxter can be downgraded for a failure to control for confounding. So this brings me to the last outcome of interest, that are serious adverse events as an outcome. Again, the definitions somewhat differ, or in some of the papers really weren't well described what was a serious adverse event. But for the Fleming and Belshi paper, I think these are fairly standard definitions. The time intervals for looking at serious adverse events were for most of the studies at the time, from the time of enrollment through the influenza surveillance period. For the observational studies for Toback and Baxter, it was in the 0 to 42 days post-vaccination. Relatedness in most all these studies was determined. The categories range from possibly, probably, or potentially, and they were all determined as per investigator in each of the studies. So in looking at serious adverse events, rates were fairly comparable between in the Ashkenazi paper between the LAIV group and the TIV group, 5.8 and 4.7%. There were a small number of vaccine adverse events or serious adverse events that were considered related to study product in both of those papers. In that particular paper. In the Fleming paper, the rates for serious adverse events were again comparable, with a few of these events in the LAIV group and TIV group being ascribed as related to the vaccine. And if you look there, there was one episode in the LAIV group of pneumonia and an asthma attack on day 2 that was considered vaccine related. In the Belshi paper, this one again reported similar rates of serious adverse events in both groups. They do note in the manuscript that most of the serious adverse events were hospitalizations. Interestingly, when you look at hospitalizations, which usually in all studies constitutes a serious adverse event, the rates were fairly similar if you look at the whole population, 3.1% and 2.9%. But then when you age stratify, looking at children who were between 6 and 11 months of age, you see that rates of hospitalization, all-cause hospitalization, were higher in that group, 6% versus 2.6%. Again, this is outside the age range of interest for our particular evidence review. If you look at the other age groups, there were no rate differences. If you look at vaccine-related SAEs, there were a fair number of respiratory events pointed out, and you can point out in the LAIV group, bronchiolitis, asthma exacerbation, wheezing, reactive airway disease. Likewise, there were several in the TIV group, pneumonia, wheezing, and there also, to point out, there were 2 febrile seizures in the TIV group. In the Toback observational study, the rate of serious adverse events was slightly higher in the TIV group, 1.14 versus 0.91 per 1,000 person months. Again, one might ascribe that to the fact that the TIV group is generally a sicker, potentially sicker population with more medical compromise or more underlying medical conditions. There were a few vaccine-related SAEs described in the LAIV group. One was a child with a right middle lobe infiltrate and fever, and one child with intussusception. In the Baxter article, the rates for SAEs were not noted to be different between the 2 groups. Of interest in the LAIV group, there were 2 vaccine-related SAEs. One included dystonic tongue posturing 3 days post-vaccination, another child with Bell's palsy 2 days post-vaccination. Looking at grading the evidence, again, the population differing from that of interest is the same as previously described for the other outcomes. And if you look here at limitations for the for the randomized trials, again, these are the same as described for the other outcomes. For the observational studies, these studies, again, failed to control for confounding for serious adverse events. And for the Toback paper, all the SAEs were described as being diagnosed in the hospital setting, possibly excluding some children who may have had SAEs outside the hospital setting. So in conducting this review, there were several limitations. There are a few studies that directly compare LAIV versus IIV. Several of the studies didn't assess outcomes of interest. The definitions for the outcomes of interest are not standardized, which is a particular problem for studies. Follow-up intervals varied across studies. The observational studies were somewhat confounded. The findings observed for fever and medically attended wheezing really only pertain to one study during a single season. It's difficult to judge any risk of serious adverse events from these trials, and it's difficult to distinguish if a temporal association between flu vaccine and an adverse event is coincidental or causal. Some caution: this review was limited to trivalent influenza vaccines that were given according to current indications, and it's really not does not include any data on the new quadrivalent products. In summary, when given according to the current indications, there's no evidence for any increased risk of serious adverse events or medically attended wheezing after LAIV versus TIV in this age group. There is evidence for some transient increased risk of mild fever after LAIV versus TIV, but this was only noted during one influenza season. That's it.
Thank you. Any questions, or shall we move on to Dr. Grosskopf? Any questions? Hearing none. Dr. Grosskopf.
All right. Hello again. Okay, with that to set the stage to hopefully sort of illustrate that the safety evaluation is a little bit on the complicated side, at least it felt that way to us, I think, relative to efficacy. We can describe what we did as far as grade for the safety. So when we do the grade evaluation, Dr. Walters sort of laid out the characteristics of individual papers and studies. What we're going to be dealing with next is pooling of data from those studies. And as you've seen, it's not always easy to do that simply because of the way definitions and procedures vary across studies. So we have made an effort to pull out some information that is hopefully clinically meaningful, but at the same time is not overwhelmingly complicated. And I'm anticipating we will get some suggestions on this and things that could be done either differently or with some different thoughts. Just a couple of comments that will apply more or less to this whole presentation, which will be somewhat briefer in overview. We're focusing on the three outcomes of fever, medically attended wheezing, and serious adverse events. We are focusing in this presentation exclusively on the younger children, the 2 through 8-year-old age range. We made a decision in doing this in our grade group to exclude the observational studies. We've had the chance to discuss them and present information on them, but there is some, particularly for the safety evaluation, an underlying concern that differences in the underlying health status of the two populations, the one that receives the live-attenuated versus the inactivated vaccine, may affect the results and interpretation of safety outcomes. So in this particular segment, we've focused exclusively on the randomized trials. So we're going to just discuss information for children 8 years, 2 through 8 years. The first set of slides, 4 of them, all relate to medically attended wheezing, and the data all come from the Belshi et al. Study, Belshi 2007. The reason for this is that we were able to get a fairly consistent definition across several different categories of children that participated in the study. We were able to get information limited to children 24 through 59 months of age, which we thought was important because there's been some concern about the younger kids and the occurrence of wheezing in the younger populations who aren't approved, not recommended to receive LAIV, but also were included for example, in the Ashkenazi paper. The first slide, one of the things about Ashkenazi's, the Belshi study is that the children in the study could either have received 1 or 2 doses of influenza vaccine. Some were vaccine naive and got 2. The children who weren't vaccine naive got 1. And the data are reported along the lines of after dose 1, after dose 2, so we were able to break this out in several ways, just as it is in the paper. So for this slide, this is data following dose 1 without regard to previous vaccination. So some of these children would have been vaccine naive, some not. Follow-up is for days 0 to 42. And this is data limited to children aged 24 through 59 months, so they're all within the indicated age population for LAIV. Considering the characteristics of all the characteristics that fall under risk of bias and indirectness, we decided that there was not a serious risk of bias or indirectness considering all of that information. We did, however, downgrade on imprecision because we have a fairly wide confidence interval that straddles 1.0. Overall, there was not, in this particular slice of the data, a significant difference in the risk of wheezing between the 2 vaccines, and we assess this as type 2 or moderate quality evidence. Looking instead, same information, sort of same framework, 24 through 59 months, follow-up 0 to 42 days, also information following the first dose. However, these are the children who were not previously vaccinated, so these are all children who would go on later to get a second dose, but they were vaccine naive at the time they had their first dose. In this particular case, we downgraded similarly for imprecision. We have the point estimate of risk does fall a little closer, actually does fall more on the side of favoring, it should say IIV rather than control on that figure. However, the confidence interval is fairly broad and straddles 1, so this is actually representing no significant difference between two vaccines. We did downgrade for imprecision, so we have moderate quality or type 2 evidence here. The next slide, this is also following dose 1, but the children in this particular section had been previously vaccinated, so these are not vaccine naive children. Point estimate falls more on the side favoring LAIV, which we might anticipate because it's not they're not vaccine naive. Still, we have a broad confidence interval which straddles 1, so we have again also a fairly broad confidence interval, downgrading for imprecision. Overall quality of evidence moderate. And lastly, among the children who were vaccine naive following dose 2, point estimate at this point is actually fairly well over into the side favoring LAIV, although it does cross one just barely with an upper bound of 1.06. We would still call this a not significant difference between the two vaccines. We also downgraded for imprecision here, so with serious concern for imprecision, so we get an overall quality of, again, type 2 moderate. Moving away from wheezing to fever, again, we thought this would be simple, but it wasn't, and we had a pretty good explanation of why that is. Ideally, we would like to pool data from multiple studies where we can, because we get bigger numbers. However, it was a little bit tricky to figure out the best way to do that in this particular circumstance because the definitions of fever did vary across studies and they were reported out in different ways. In this particular table, what we have a fever defined by greater than or equal to 38.6 degrees Celsius, which is roughly 101.5 for the Ashkenazi paper, and for Belshi, greater than or equal to 38.9, which is roughly 102 degrees Fahrenheit for the Belshi paper, and we have pooled those. And this is follow-up for days 0 to 10. So it's a little longer follow-up than what Dr. Walter reported when he discussed some of the earlier fever outcomes. For example, the slightly increased risk of fever during one season for 2 days post-vaccination. We have a slightly longer interval here. And again, the temperature thresholds do differ slightly. For this, we have again we have a slightly broad confidence interval. The grade handbook recommends considering downgrading for imprecision when the lower bound crosses 0.75. This goes to 0.73. So we did actually call this. We did make a call for downgrading for imprecision in this particular analysis, and we're calling this type 2 moderate. But no significant difference between the two vaccines, at least according to this analysis. The last data slide here I have is SAEs. We're focusing here on related SAEs because we were trying to get something a bit more specific. So these, again, related SAEs would be serious adverse events that in the judgment of the investigator were probably related to vaccination. You saw some of the characteristics of some of these SAEs in Dr. Walter's slides, the related ones in particular. Most of them were related to respiratory symptoms. And because those were relatively uncommon, even less common than the total SAEs, we don't have, the data are somewhat sparse. We have a particularly broad confidence interval here, did downgrade for imprecision. Again, we have data that crosses 1. We have not assigned a value to this particular outcome because it's not completely certain how meaningful it is. We probably will have more discussion about that within work group, although there wasn't readily apparent consensus from work group about how they would want to value it. We did feel it was important to look at because some of the more rare and serious outcomes are so rare that we could not get an accurate assessment for them, and we're hoping to use this as some sort of proxy to see if we could find anything, but we did not. Overall quality of evidence here was judged to be type 2 or moderate. So to summarize for these three outcomes, critical medically attended wheezing, no difference, type 2 or moderate. Fever, important value as an outcome, no difference, type 2 or moderate. Related S or E, no difference, type 2 or moderate. Moving on to limitations, Dr. Walter addressed some of this in his talk, but I'll just reiterate it because I think it probably bears repeating. The definitions of the outcomes of interest are not standardized across the studies. There are some differences that make it actually really fairly tricky to determine how we might pool data in a way that's both meaningful and will allow us to get a better assessment with somewhat better power from better numbers. Studies also here are not adequately powered to detect differences, potentially differences in some of the events we've looked at, but also differences in some of the rare but serious and important outcomes. For example, Guillain-Barré, anaphylaxis, immediate hypersensitivity, febrile seizure. We would not be able to assess those from these studies. Those are things that would probably be better evaluated in larger population-based studies, which we haven't evaluated here. And finally, again, all of these data pertain to trivalent vaccines because those were what were available when these things were done. With that, I'd like to thank everybody that assisted with this evaluation. We appreciated the ability to have Immunization Safety Office and CISA input on this as we formulated the approach to things, and also like to thank everyone else on this slide. Thanks. Be happy to take any questions.
Thanks very much for a very clear and succinct presentation that pulls it all together. Are there questions from the committee or liaisons? Dr. Karen.
Thanks very much, Lisa. I just had a question. There was one slide, I think it was maybe your fifth slide. It was first dose in naive children where clearly the confidence interval crossed 1, but it looked like there was that there was a trend. And I seem to remember that in our work group, we had also looked, so this was 0 to 42 days. And I think we'd also looked at a shorter interval that was more related to the period of LAIV replication. I think the FDA maybe had given us those data. Mm-hmm. And I was just wondering if you can remind us of how that looked relative to this.
We did. There are actually two things. There's one slide which is not included here because strictly speaking it didn't meet our criteria for medically attended wheezing, but the Ashkenazi paper reported for days 0 through 11, they did report wheezing as an outcome, but it was reported on diary cards from the parents, so there was no practitioner verification that had occurred. And we did look at that in work group, but we didn't include it here. The take-home point from that was that there was no difference between the two. We were able to get some information from FDA with regard to earlier wheezing during earlier intervals for children 24 months and up, which basically going out during the first 10 days following vaccination to show no difference in the rates of wheezing. And those data came from the Belshi study, and I will try to get that out to folks following the meeting.
Any other comment? If we can then, I guess, ask, is it Dr. Conlon?
Thank you to the committee and good morning. I have a very brief supply update this morning on LAIV. Before I do that, though, I would like to just show one slide that are present in your backups. And this is in response to the question that was raised earlier about the relative efficacy of LAIV in vaccine-naive children or children who have been vaccinated previously or have experienced influenza. And this slide shows there were 4 placebo-controlled studies that were done during the clinical development of LAIV. 4 of those studies were 2-season studies. So Those studies are shown on this slide. The first efficacy, and this is absolute efficacy compared to placebo. So the first study that we're looking at is the Belshi study. First season, absolute efficacy of 93%. Second season, after revaccination, was 100%. The Vesicari study, 85% first year, 89% second year. Bracco, 74% efficacy in both years of the revaccination, and then the TAM study, 73% efficacy the first year, 84% the second year. And these studies were performed in children that are not in the exact age group that we're talking about today, 2 to 8 years. These children were generally younger. Then the other piece of information that's relevant to that particular question is in the large Belshi study that was conducted, that was the head-to-head trial of LAIV versus TIV. And in that study, he actually did analyze children who had been vaccinated previously with IIV and compared that to children who weren't previously vaccinated with IIV. The efficacy was similar, whether or not they were previously vaccinated. If they were previously vaccinated, the efficacy was 51% fewer cases with LAIV compared to IIV. In the reverse situation, when they were not previously vaccinated, it was 57% fewer cases in the LAIV group compared to the IIV group. So that's the information relevant to that question. So I would just like to turn then to this brief supply update that I need to give today. So just for clarity, the seasonal live-attenuated influenza vaccine is approved in the US for eligible individuals 2 to 49 years of age. It contains 6.5 to 7.5 of each vaccine strain per dose. And the quadrivalent was introduced in the United States starting in the current 2013-14 season. It contains no preservatives or adjuvants. It's stored refrigerated and is administered as a nasal spray. There have been more than 75 million doses of the LAIV distributed in the United States since its licensure in 2003. Okay, this slide shows the total doses of LAIV produced by season, starting in 2003 when we were licensed and going up to the current time. In the early years following licensure, the production was very modest, as you can see, but it's increased after around 2008 when the product was licensed down to age 2, when it no longer had to be stored frozen in a freezer, and when ACIP recommended routine annual vaccination of all children. So we've seen the increase. I also want to point out to you that large spike in 2009 is the combination of the pandemic and seasonal vaccines. And so you can see the gradual increase in production. For the 2013-14 season, we produced 22 million doses, of which about 13 million have been distributed in the United States. We're planning to produce about 24 million doses in the upcoming 2014-15 season, unless additional information justifies either increasing or decreasing that number. So I also wanted to show this information. LAIV has been increasingly administered to U.S. children 2 to 17 years of age. And the data on this slide is from a large national insurance claims database, and it excludes the pandemic doses. So this shows the percentage of claims filed by privately insured children for influenza vaccine by vaccine type and by year. So this slide shows the actual usage starting in 2007, 2008, and going up to 2011-12, which is the most recent data that we have. And it shows the proportional use of IIV in multi-dose vials, which is shown in the white bars. The stippled bars show the use of the pre-filled preservative-free syringes of IIV, and the solid blue bars show the percentage of claims that were filed for live-attenuated influenza vaccine. So you can see that over this time period, the use of multi-dose preservative-containing vials decreased from 69% in 2007-2008 to 35% over in 2011-2012. In contrast, the use of the pre-filled syringes of IIV has increased in this period from 19% to 25%. And you can see the use of LAIV has increased from 12% to 40% in 2011-2012. The information for the current season are just starting to come in. It looks like these trends are continuing and that the percentage of LAIV is about 44%. So I've shown you the increasing use of LAIV, and I've also shown you how we have increased our production in order to meet the demand for increased number of doses. So in the next slide, I would like to show you our capacity for responding to a potentially greater demand for LAIV in the United States. So this shows the current and projected LAIV manufacturing capacity compared to potential demand. And the data on this slide, the estimates assume a 50% overall vaccination rate among U.S. children 2 to 17 years of age using any vaccine type. So that's the current coverage that we have approximately. And looking then at the 2013 current season, you see a demand for LAIV of 16 million doses, 13 million in the U.S. and 3 million ex-U.S. And in the horizontal line, you see the manufacturing capacity that we have for making this. And you note that there is a large amount of unused manufacturing capacity that we're not using right now because we have a capacity to make 30 million doses, but we've only had to make 16 million doses. If you look going forward to the 2014-15 season, and if you took a theoretical demand that 70% of all children that are eligible for LAIV would get it. So you go from the current situation where there's a 40% market share, and if you would say, what would happen if you moved that to a 70% market share in either 2 to 8 or 2 to 17, you would come up with this kind of a demand, which again is met adequately by our manufacturing capacity. If you move on, you can see that we would predict that in 2015-16 we'll again be into a situation of excess manufacturing capacity because our manufacturing capacity is going to increase to 35 million doses then. And I would add that if you assume that going forward in the United States, if we meet the goals of the Healthy People 2020, where you actually reach close to a 70% coverage rate, we will be able to make that even with these higher market shares, because we plan, as noted in the footnote, that we will be going to 47 million doses for the 16-17 influenza season. So summing up, our current and projected manufacturing capacity for LAIV is sufficient for eligible U.S. children at both current and higher future LAIV use, at current and higher future vaccination coverage levels, and to meet both U.S. and ex-U.S. demand. And additional increases in demand could be met by further increases in manufacturing capacity. Thank you, and I'll take any questions that you might have.
Dr. Karen.
So thank you, Kathy. I want to understand the relationship between capacity and supply in any given year, and also how those relate potentially to our future policy decisions. And what I mean by that is, there might be a situation where we have a clear preferential recommendation for LAIV in a certain age group. There might be a situation where we talk about consideration of use of LAIV in various age groups. How does that affect year-to-year supply?
That's a big question, Ruth. I hope I can answer it, but I think that this slide says a lot. Okay, so this shows a current situation. It's hard to predict what kind of demand would be triggered by a preference in the United States. We just chose look at 70%. If you look historically at the ACIP recommendations, when the ACIP makes a recommendation for a new vaccine, it doesn't trigger this automatic movement toward that, following that recommendation. It always takes a few years for that to go into effect. So you're kind of guessing what might happen, but we thought that modeling this over the next few years would provide some reassurance that the capacity is adequate and that we just have to use it. Because as I would point out, we're only using half of our capacity now, this year, right now, for the current season. And that is expanding to 47 million doses by the 16-17 season, which would be adequate, in our estimation, to cover everybody who would be likely to want to get it.
So can I just sort of ask a follow-up to that? Flu vaccine is the most perishable vaccine of all, right? It comes and it goes, and obviously a company has to weigh demand against capacity, and you might not produce all that you can produce if you can't use it. And so I guess what I was driving at, as well as in terms, not just in terms of absolute capacity to produce, but as in, I guess, trying to understand more about the forecasting process, which is probably very too complex even to discuss, but depending on policy recommendations. But anyway.
Ruth, policy recommendations are taken into account. Like I said, it's not like an instant turning on the hot water and people follow recommendations right away. As far as forecasting, I certainly am not involved in that, so it's a little bit difficult for me to answer that question. Clearly, policy plays a huge role, as you well know, in how the demand for vaccines. And it's going to be even more so going forward with our changes in healthcare.
Dr. Sawyer.
I just want to make sure I understand this slide. I think it's based on a 50% immunization coverage rate overall. Is that correct?
That's correct.
So is there a coverage rate at which you would no longer be able to meet the demand? Let's say we were at 70% coverage rate and 70% of those children receive LAIV.
We actually did model that just for simplicity and to keep the number of slides down. I didn't include that. I just wanted to put it all in one slide. But if you do increase that up to 70% and also look at a 70% market share for where it's adequate, yes.
Ms. Stinchfield.
Patsy Stinchfield from NAPNAP. I'd like you to comment on the true eligible children. And as a work group member, we talked a lot about those kids for whom flu vaccine is contraindicated. And so what are the true contraindications versus what we have in our ACIP statement, which talks about healthy children? And I think that defining that clearly really does impact who we're giving it to, and therefore your supply and your projected capacity. So if you can talk about true contraindications.
Well, I think the difficulty is that what is a true contraindication? So I think you mean the legal regulatory contraindication as given by the FDA. So the contraindications in our label, which is issued by the FDA, are for, children who are on aspirin therapy, and anyone who is allergic to a previous dose of vaccine. So it could be allergic to the vaccine itself or any excipient, or, for example, eggs. So I can't really comment. I'm in an awkward position, you recognize, to talk about true contraindications versus what ACIP recommends, because of course we have to take the judgment of this committee. That's what this committee does. So,
And I just want to follow up. I didn't mean to put you in an awkward position, so I apologize if I did. But I think the point is to highlight the difference between those two true contraindications and healthy 2-year-olds and over is quite a big difference. So we need to talk more about that.
Dr. Karen.
Just to sort of follow up on Patsy's comment, and I think actually we should just probably also say that in terms of label, true contraindications, immunocompromised is probably the third category besides aspirin recipients and allergic children. But I was actually wondering if our NACI colleagues, or I don't know if there's anyone here from the UK, places where LAIV is being used in children with previous history of wheezing, whether they have any kind of registry or data collection to tell them about adverse events that occur in these populations, because I know LAIV is used differently in some other countries.
Any comment from Canada?
Brianna Warshawski from the National Advisory Committee on Immunization. We do have a vaccine adverse event registry, just as you do, a passive system for reporting. I'm not aware of a particular analysis done on LAIV, but I'm also not aware that there's been any safety signals brought up. So nothing's been brought to our attention with regard to LAIV using.
And how about Dr. Salisbury?
David Salisbury from the UK. So far, we've only been vaccinating 3-year-olds and 4-year-olds this winter, and we have 40% coverage with LAIV in those two age groups. But I'm not aware either of any specific adverse events, because so far we have been only using the license-specified indications and contraindications. So anything that comes from use outside of the recommendations certainly hasn't surfaced yet. The other difference is that we are only using one dose in all of our age groups from 2 upwards with LAIV, on the basis that the incremental advantage of the second dose doesn't really seem to warrant its use. Thank you.
Sorry, David, just a follow-up question to that. I think if I understand the contraindications to use of Fluens, which I think is your European product, it's children with severe wheezing or active wheezing at the time of immunization. So it doesn't. So that would be outside the label, but it wouldn't exclude children with any history of wheezing.
It's closer to the Canadian situation. Yeah. Thank you.
There was a gentleman up at the microphone.
Yes, thank you. Lance Miner, MedImmune, Operations Strategy and Planning. Just to address Dr. Karen's question regarding forecasting versus planning, we do plan to produce additional bulk and finished good material every season above and beyond the expected demand. And then we have options mid-season to produce even further.
Thank you. Other comment? Dr. Groskopf, I think we're ready for the proposed recommendations.
All right, thanks. So as I mentioned at the outset of the session, at present, the work group is not proposing any changes to the recommendations for next season. We will have an opportunity to discuss more changes in June should there be the need to do that. And there are some topics that continue to have some ongoing discussion within the work group. What we had planned to do today was basically just sort of reiterate the core recommendations for annual vaccination being recommended for all persons aged 6 months and older. We have begun to draft a policy note for the MMWR for next year. As most of you know, for this season, after 2 years of having recommendations done as policy notes, just with short pertinent updates, we did for the 13-14 season go back to a full format MMWR R&R, and having done that, we plan for next season, unless circumstances change, to go back to the smaller policy note format. That document has been drafted and consists right now only of those items that are known or it's assumed that they're not likely to change, and the ACIP members have received a copy of that for review and comment. Any proposed changes we intend to have discussed and presented at the June 2014 meeting. Another thing to note is that this time last year we had a lot of new products that either were out or were on the horizon about to be licensed. As of this point in time, we are not aware of any new licensures. There may be some between now and June. Currently, in the draft policy note, all of the licensed vaccines are summarized in the draft table, which is essentially, at this point, identical to the current season table. It will be updated, of course, as new package inserts are out, and also with any new licensures as they occur. And also any new licensures that occur between now and June will be discussed at the next meeting. For today, we're mainly just proposing reiteration of the core recommendations for vaccination for everyone 6 months and older. Now, just one little brief thing, the vaccine strain selection for next season. The World Health Organization has had its strain selection meeting and has recommended the same composition for the Northern Hemisphere vaccine for 2014-15 as has been used this season, 13-14. That will be discussed at the FDA VRBPAC meeting to make a final decision, I believe, this week. So we do not yet know for certain what the strains for the U.S. will be, but of course that will be discussed at VRBPAC. For the time being, those are represented in the draft with some placeholders until we know that information. I want to thank everybody that's involved in preparing all of this. In particular, I want to thank Sonia Oslam and Leslie Sokolow. We've been working together on the grade stuff and have been spending quite a bit of time together. That is all I have for this, and any questions are welcome, please.
Thank you, Dr. Grosskopf. I see a couple hands up, so Dr. Harrison.
So in terms of proposed changes, what information will we have in June that we don't have now?
Well, thought I heard something else, sorry. For one thing, as mentioned, one issue with regard, for example, to any language related to LAIV and IIV, even if there were not to be a preference, we've done the grade analysis and we'll have some sort of summary of that either in or linked to the policy note. Because policy note is such a short format document, it will probably be a URL link in the document. Typically, the entire document is not put into the MMWR. But as mentioned, a couple of presentations back, one issue that is also harmonization with AAP, which is something we aim for. And the AAP will not be meeting on this topic until April.
Dr. Dushan.
Thanks, Lisa, for your multiple presentations this morning. Yeah, I just wanted to follow up on the issue of preferential recommendation for LAIV, and for our colleagues on the ACIP who aren't part of the influenza work group, it might have been a little bit vague, that we're really strongly considering a preferential recommendation, and it would be great if they could actively think about that in the time between now and June, since we're not going to have the opportunity to vote on that today. Many of us feel that it's long overdue, and we have a vaccine that even CDC has acknowledged on a public web page is superior in young children, yet we haven't gone that step to make the recommendation, which does influence a lot of healthcare providers. So just want to make sure other colleagues understand that that's under serious consideration for the June meeting.
I'd like to follow up on that point just a little bit as well, and then I also have a question. But the point is whether or not the ACIP members would request that the influenza work group proceed with language and such a recommendation for a preferential use of vaccine, keeping in mind also just the timing for clinicians and health systems to do ordering, that last minute things, ideally when I put on my clinician hat, things coming in October is appropriate for kind of the following year for ordering. So I think we just keep that in mind. That said, the follow-up question I think is for Dr. Duchin and also for Dr. Newsel, both from state of Washington, where you have a preferential recommendation for the live-attenuated in children. Can you provide us a little bit more information on that?
I presume you're referring to the impact that it might have had on, use of that the LAIV. Yeah, unfortunately, our recommendations don't carry the weight of a recommendation from the ACIP, and it's not really clear that they have the penetration that we would desire throughout the clinical community. I like to take the opportunity always to remind our clinical colleagues that there are data that suggests the LAIV is better in younger children, that the CDC has more or less endorsed that data by posting that on their own website without making the formal recommendations. So in the context of ordering vaccine, I think clinicians should keep that in mind, that there are already, there's already data available to suggest that that's a wise thing to do for younger children. We don't have a specific cutoff yet, which would be probably useful for some. But there hasn't been any issue with shortage. The supply's been adequate, and I think many physicians are aware, but do wait for a more clear guidance from the ACIP before sort of changing large system practices.
Thank you. Dr. Harrison?
I know the meeting is in April, but can we get a sense for where AAP is on this issue?
I mean, we haven't really discussed it. We're going to discuss it in April, as was mentioned. So I can't tell you that. I can't tell you that there's a consensus yet amongst the group. Some of this information is just going to be presented for the first time at the meeting.
Thank you. We have Dr. Kemp.
Yeah, I think that the data seems pretty strong and compelling in a lot of ways. I think that one thing I'm wondering about is, I think if, in fact, there is a preferential recommendation made, it's going to put front and center this issue of wheezing. And, as well-defined asthma is fairly straightforward, but as any of the primary care providers in this room know, in young children, there's a lot of kids that have wheezed or have wheezed in the last year but do not have a diagnosis of asthma. So I think if we make such a preferential recommendation, I would like to discuss a little bit more where the current precaution, not contraindication, came from, and whether we can pin that down a little bit better given data of whatever type from other countries, for example.
Dr. Bennett.
Thank you. Lisa, I just wanted to clarify what you were saying about the recommendations, the yearly MMWR on influenza. Were you saying that if we made a preferential recommendation in June, that it would be too late for the recommendations?
No, we've had votes in June. I think actually as long as I've been doing this, we've had votes in June, despite trying to not have votes in June, because and I apologize for that, but it just seems to happen. It is too late in the sense that ordering has happened by that point. But on the other hand, because there's always so much going on with flu, one might make the argument that we sort of have to consider things as they come along and try to keep things moving. It wouldn't be too late to go into the MMWR. Among the concerns that some people have expressed about having a preference on the work group, if I may summarize those, there's the fact that ordering will have happened already. so hard to implement for the 14-15 season. On the other hand, there's precedent. For example, I can't remember exactly when it was. It predates my involvement in this somewhat, but as the recommendation for vaccination was being expanded into broader ranges within the pediatric age group, there was a year when the recommendation was vaccinate this age group, if feasible this season, implement completely by the following season. So that's one thing that can be done there if that's the case.
At the microphone, please.
Hi, Katia Ferreira from GSK Medical Affairs. Thank you so much for the great presentations, great work. We were just wondering when we would include the quadrivalent influenza data as well for efficacy, where we have results in the 3 to 8-year-olds, when that's going to be analyzed as well.
I couldn't completely understand the question. I'm sorry, can you repeat?
The question is related to when will we have also a review of the efficacy data available for the quadrivalent vaccines and the recent study just published in NHM with relation to the efficacy of quadrivalent in this population as well.
So quadrivalent versus trivalent vaccines?
Quadrivalents, yeah.
As usual with flu, there are a lot of topics to be discussed, and that is something we will likely be discussing at a future date, although I can't say exactly when.
Dr. Lair.
So Jamie Lair from the AAFP. As a member of the work group, I guess I respectfully disagree with Dr. Kempe and focus mostly on, can we just get a preferential recommendation agreed upon or not, and not worry about the details of wheezing at this time. And I'd ask the work group to give guidance, the ACIP to give guidance to the work group. What would you need to feel comfortable voting on a preferential recommendation in June? Because that's what the work group is wrestling with right now. My understanding is that there hasn't been a preferential recommendation. So are there other issues that you'd like us to explore before we bring this back to June? Because many of us feel that we would like to have a vote on this and with some language for a preferential recommendation in June.
Dr. Harrison. Dr. Rubin, I'm sorry.
Yeah, I'm pretty much compelled with the data as well. As we discussed in a previous meeting, one of the hang-ups was that the quadrivalent LAIV was a new product. And so I guess I'd like to at least see the VSD data, as I mentioned earlier, honed down on the age group that we might potentially be giving a preferential to see if there's signals for seizures in particular. And of course, quadrivalent inactivated vaccine as well, if there's sufficient data to make that point.
Dr. Bocchini.
Yeah, just harmonization is really important so that we have a single message. I'd really like to see what COID reviews and have their input so that we could potentially go forward together in a harmonized way.
I think that's a very reasonable approach. And if there's anything that we can do to facilitate getting the great information to COID, that'd be wonderful.
Yes, Ruth's going to come up with
that. At this point in time, I think we do have the potential for a vote for the recommendations as presented by Dr. Grosskopf. I'm wondering if there is any motion for that. So moved by Dr. Bocchini. And do we have a second? Dr. Dushan. Any discussion? And this is just limited to the, actually, if you can go back a slide. And you had a comment, Dr. Kern?
Yes, I think that the recommendations as they were sent to us had a sort of a red highlight for issues related to contraindications with respect to LAIV, and I think that that was an issue that the work group was going to specifically take up and that might come up again in our June meeting. And so as we vote on this, I don't know if there is a way to incorporate the fact that because those are part of the annual recommendations, and yet we may reconsider those. So I don't know the best way to approach that.
I think we could just, as part of the minutes here, make a strong suggestion to the work group to consider those issues, as opposed to putting it in the recommendation per se.
So I guess my question is, if I voted yes, am I voting to approve the current recommendations for limitations of use, and how does that work?
May I comment? At least based on my understanding of, and please, Dr. Tempe and Dr. Pickering, correct me. What Dr. Karen is referring to is there has been, for the last several seasons, a footnote in the table of available vaccines that concerns one of the issues we've discussed in the last couple of presentations surrounding groups for which there's a precaution against LAIV use. For example, folks with chronic medical conditions, and there's also some wording related to asthma. And that table in the version you've seen, or that footnote in the version you've seen, is red and is marked with a comment indicating that there's going to be further discussion of that between this meeting and the next. My further understanding, though, is that also there's opportunity to make changes at any point if that's necessary, and the committee votes on it. For example, we tend to have updates to the table based on new package inserts and other information. But that section is marked as being currently under discussion.
Is there any comment, Dr. Sun, from FDA regarding?
I'm not sure what specifically you were asking for comment on.
Well, currently there is a package insert which states the contraindications and the precautions and so on. And my suspicion is those would not be changed at all. Those are standing.
Yes, just by way of kind of background, there are only certain ways in which we can revise the label, the package insert, and the most common way is when presented with data from the manufacturer concerning the specific topic change. The second method is that there are specific safety concerns that are raised that have been come to be known, and there's such seriousness that needs to be in the label, in which case FDA can make a safety label change. But those are the only really two mechanisms to change label. So unless that we're presented with additional data on the safety, wheezing and flu mist, we will have to look at that data and consider what that implication would be for any changes in the label. So if there's no, and MedImmune can probably comment on this, whether they plan on submitting such data or working with us to develop such data.
Dr. Kerr?
So John, just as a point of clarification, so right now the label from the FDA has fairly narrow contraindications, and Kathy actually explained what those were. The current ACIP recommendations, as I read them, lump together the contraindications and the precautions. And so I think that the question that the work group really wants to work on is, should those in fact be lumped together as one, or precautions are different from contraindications, and should we consider those separately? So that wouldn't require something specifically from the FDA. That would require us to review what's already in our recommendation.
Dr. Kemp?
Yeah, just to clarify from the comment from the AFP, I think that I personally have enough information to be in favor of making recommendation in June. But I do think it's important to more specifically get into this, because it is going to put it front and center. So I didn't mean to imply that would hold up the decision.
Dr. Rubin?
I'd just like to clarify what we're being asked to vote on now. As best I can tell, it's a reaffirmation of last year's statement with changing 13-14 to 14-15 and new players to be named later or something.
Yeah.
I think you're calling that correctly. I saw a hand up with Dr. Sun.
Yes, I just want to follow what Dr. Karen had said, and perhaps it may be useful to make a distinction between contraindication and warnings and precautions in the package insert. So we do, of course, have very specific definitions of those, and so please bear with me if I can just describe that. So a contraindication, according to the FDA, is we're describing any situation in which the drug should not be used because the risk clearly outweighs any possible benefit, and that there is substantial risk of being harmed for the patient for whom there's no potential benefit makes the risk acceptable. And these are supposed to be known hazards and not theoretical possibilities, whereas warnings and precautions, it merely describes clinically significant information that would affect the decision on whether to prescribe that drug, and also any recommendation for patient monitoring that are critical to safe use of the drug, and then any measures that can be taken to prevent or mitigate harm. So it's very different from a contraindication in that the risk benefit it may be very different, and that's I think becomes a judgment call based on the advisory committees or the healthcare provider.
Thank you. Further up at the microphone.
Sure. Chris Ambrose in Medical Affairs at MedImmune. Just to respond to the request from Dr. Sun about submission of data, we actually do have an active submission with the FDA where we've submitted the data from the Fleming study. It has the safety data in children with asthma, as well as data from the Belshi study and the Ashkenazi study, in which younger children who had a history of wheezing or asthma. We've submitted that data, and we are in conversations with the FDA about that. So we look forward to working with them to see the resolution of that submission. So,
Ms. Infield.
Patsy Stinch from NAPNAP. The reason I raise this is you play it out and we have a preferential LAIV, but we use our existing language that precludes us from using it in children with metabolic disorders. I, as a clinician, I'm going to have a hard time talking to a diabetic and saying this is a better vaccine, but you can't have it because you're not considered healthy. So wheezing aside, I just think we have to really be clear about our true contraindications and those precautions that would allow us to open it up for use more.
Dr. Freihofer?
Sandra Freihofer representing the ACP and the AMA. As a clinician, I think you pointed out that we have to do our ordering now, and I think it's going to put clinicians in sort of a strange place if you order now and you order based on the current recommendations, and then come June, what you've ordered is not what's recommended, and or that possibility. So it does put clinicians in a weird position.
Dr. Dushin.
Thank you. Two comments. One, to follow up on Pat Stinchfield. I completely agree, and I think that would be the task for the work group to come forward to clarify that language and to address those concerns, which many of us feel are not beneficial right now, the way they're described in the statement. And then just secondly, around the issue of ordering, it's, from my perspective, we do a lot of ordering, in the public health department, and we advise clinicians on ordering. We're a universal state. There's always a problem with ordering. Things never synchronize. And so we have two good vaccines out there for children. Clinicians already know that LAIV may be better in younger children, and they can take that into account when they order now, and they can anticipate they may be seeing some more strident or more directive language from ACIP on this, but it's not going to put them in a very poor position to have, more or less LAIV versus IIV either way, because both vaccines are good, and there's always a transition period when new recommendations are made before everybody comes on board. So I think, people may not have the optimal mix that they would desire, but they certainly will have good vaccines that they can use in all their patients either way.
Does that give enough feedback to the work group to bring things back in June? Very good. The other point I'll just throw out really quickly is, in my mind, the biggest problem out there is we underutilize influenza vaccines in general for children, and especially in school-age children. So is there any further discussion? Why don't we go ahead and do a vote? We'll start with Dr. Reingold, and we'll go to your right.
I vote in favor.
Evers Alcolt, yes.
Karen, yes, with a proviso that we re-examine some of the issues we described.
Tucci, yes.
Tempte, yes.
Bennett, yes.
Pellegrini, yes.
Rubin, yes.
Harrison, yes.
Vasquez, yes.
Coin Beasley, yes.
Harriman, yes.
Jenkins, yes.
Camp, yes.
Bocchini, yes.
Thank you. The vote is unanimous. I don't believe there's any, oh, pardon? I already did. I don't believe there's any VFC resolution that needs to go with this because it's already existing.